Good afternoon and welcome to Clinical Pearls. I'm your host, Curry Bordelon. You could join our discussion today by typing your question into the chat box. We'll answer as many questions as we can during our time together. Today, we're delighted to have experts to discuss COVID in nursing practice. Thank you all for joining us today. First, we'll start with, as we get started today, we're going to go around the room and let everybody introduce themselves and tell us a little bit about the work that they're doing. Dr. Suzanne Foger.
Good afternoon. I'm Dr. Suzanne Foger. I'm a professor at the School of Nursing in psychiatric nursing, and I also have two clinical practices. The first working with patients at 1917, which is an HIV positive clinic, and I help people to manage many times their trauma and to live life as well as possible. And I also have a clinic at Cooper Green where I see patients with chronic pain.
Excellent. Thank you for joining us today. Dr. Tina McGinnis.
Hello, I'm Dr. Tina McGinnis, and I am a psychiatric nurse practitioner. I am a professor emerita from the UAB School of Nursing, and I have a passion and interest in the well-being of Alabama's citizens, especially as it relates to nursing workforce post-COVID.
Thank you so much. We're excited to have you and look forward to hearing from you. And last, we have Ms. Paula Levi.
Hi, everyone. My name's Paula Levi. I'm a third-year doctoral student here at the UAB School of Nursing, and my research focus is PTSD and ICU nurses.
Excellent. Thank you all for joining us, and thank you, Paula, for sure, because I know that you've done extensive work or doing extensive work in this area. I think it goes without saying that COVID has really impacted all levels of the healthcare system. It really has. This ongoing pandemic that we've been still in right now, it continues to put enormous pressures and so forth into all levels of the healthcare environment, especially in the intensive care. And I know, Paula, you're continuing to do a lot of work talking about psychological trauma for nurses within the healthcare setting. Can you talk about some of your work and what you're seeing?
Yes, ICU nurses have experienced unprecedented psychological stress and trauma, and major sources are the high death rate despite their best efforts, witnessing many patients die alone due to visitation restrictions, hearing the heart-wrenching last words of family members to their dying loved one on telehealth or their phone, and moral distress from providing fetal care. This can occur when they feel they're prolonging pain and suffering of patients they feel will not survive.
I know this can be quite troublesome and very difficult for a lot of the families, and not only the families, but certainly the caregivers who see this day in and day out. Can we talk a little bit, while we're on this topic, and specifically the population of the intensive care nurse, can we talk a little bit more about, we were in a space where the newness of the pandemic, we had some reprieve, and then we got another wave with the Delta variant. What were you seeing in the nurses in that space? Were they able to cope and adapt and then come back, or did you see them in a new space of challenge?
It was definitely very challenging for them. Many of them are very young and felt they were just too young to have witnessed so much death. Even nurses that were more experienced were, they've just been challenged by COVID-19, and some of them have left their positions for a less stressful position, or also others have left just to have a higher pay through travel nursing, and this has put on increased workload for the nurses who've remained.
We know this for sure has put an ongoing stressor for a lot of the different parts of the healthcare system. And you mentioned travel nursing, and we're going to touch on a little bit about that and some coping mechanisms and so forth as we move forward. But I'd like to bring in some of our other experts when we talk about this repetitive, ongoing trauma that occurs within our population of nurses and healthcare providers when we get to the point of PTSD. And I know both Suzanne and Tina have some experience with that. Suzanne, can we talk a little bit about how this repetitive or cyclic ongoing psychological trauma, how does that impact individuals, and where do we get to the PTSD point?
By definition, PTSD requires an individual to have the experiencing of the distress for more than 30 days. So, in the sense is that with the nurses in any particular location in which they're extremely stressed by COVID, such as the ICU nurses, um, many of the coping strategies that they may have had are challenged. With COVID, more isolation takes place. And with PTSD, one of the treatments for it is against isolation, so that people use a buddy system to help manage. And many of the nurses, when they were in the COVID situation, they felt that they couldn't really utilize their families because of concern of bringing COVID home. And so they isolated themselves to prevent the fear and the concern of contacting and in essence bringing COVID home. So there is disturbances of sleep, disturbances of appetite, feeling that they relive the situation over and over again, and many times their sleep experiences are impacted so that they have no rest or respite from the ongoing and constant thoughts about the experience that they've had. So this particular graph that's showing right now is from the American Nurses Foundation in terms of nurses' experience during COVID and how many of them felt stress and exhausted, which leads to compassion fatigue when nurses, for the most part, their whole being in caring in requires that they are engaged and compassionate with their patients. But when stressed and exhausted and overwhelmed and anxious, it's very difficult to be compassionate towards your patients or each other when you have no reserves, which increases the distress of the nurses because what they treat with, the very compassion, is essentially on empty.
You bring up such a good point, talking about how that ongoing repetitive injury can lead to PTSD, but can help curb that is in fact being able to recharge, be able to refill, to reconnect, and that isolation element certainly challenged it even more. So, Tina McGinnis, can we talk a little bit about how, from your expertise within PTSD as well, what are some of the end results? What do we see with those patients in that chronic state?
So the UAB School of Nursing has worked a lot with the VA to understand and remediate cases of PTSD that our students, when we work with veterans and also our faculty in joint partnerships with the VA. So we have a lot of experience and understanding about what PTSD is. And as Dr. Foger was saying, one thing is for sure, one very effective treatment is for people to be together. We have social brains and we need to treat ourselves as social individuals. It really renews us to be around one another. And of course, one reason that the Lancet recently published an article stating that there's anywhere from 28% increase of anxiety disorders, and I think the statistic was 26% increase in depressive disorders around the world, according to their epidemiologist, is because we have been very isolated in many ways. And of course, that spills over into with our families and our children. And so many nurses have children and families, and they have, as Paula mentioned, a lot of concern that they could actually bring home COVID virus itself, and the links that they go to prevent that. Showering in a bathroom, for example, specifically dedicated to the nurse working in the ICUs with COVID. That's one of the strategies. So one nurse said to me, she feels like that the various waves of COVID are almost like being in the military, that they've had multiple deployments with COVID. And we know from the experiences of veterans who have been deployed multiple times during Operation Iraqi Freedom and Operation Enduring Freedom, that the more times you're deployed, the more stressful things become and the more cognitive burden you carry with you because you've seen so much and you've endured so much. And so I think with nurses, and Paula can address this even better, they've seen so much and they've seen it repeatedly, and now they're feeling like they're veterans of the COVID war.
Excellent. Thank you so much. That certainly lends a great insight to and a comparison that's very attainable when you think about military families, and we understand how that repetitive cycles of deployments and so forth does put additional stressors onto the families. And Paula, I'd like to spend some time talking about, you mentioned earlier about psychological trauma, and we spent some time talking about that, but you also mentioned something about compassion fatigue. Can we spend a little time talking about compassion fatigue? And nurses already in vulnerable populations and vulnerable environments, such as the intensive cares or the emergency departments or the neonatal intensive cares and so forth, those nurses were already stressed. And now we've added something on this, which is an uncontrolled pandemic, which is now in a better place than it was before, and how that compassion fatigue really put pressure on the healthcare providers.
Well, they're just experiencing day in and day out, seeing numerous patients die, or they're just very, very ill, and it's just not ceasing. It's just relentless, and so it's hard to face this continuously at work. So they are experiencing compassion fatigue. Not everyone, not all of the nurses, of course, but it is something that happens when you just see it so much.
This is so true, and it does. It wears on the system, and it wears on everybody around you. But I do want to take a step back. We spent some time talking about COVID, and that's really is a lot of the focus of what we're going to talk about today. But adding in that is a lot of collateral issues. There's other issues that feed into the day-to-day function of an intensive care. And it goes beyond just COVID. There are other things that are in there, whether it be staffing, whether it be procedurals issues, whether it be the fact that there's, travel nursing, whatever it might be. Can we talk a little bit about some of the other factors that play into that environment of additional traumas, because it might be small here and there, but those traumas add up, play into the intensive care, the day of the intensive care nurse. So anyone who'd like to talk about that. So Suzanne, can we spend some time talking about the other ancillary traumas that push also alongside COVID in the ICU?
We can talk about ICU, but we can also talk about nursing in general, because many times when folks come into nursing, they bring with them their own family experiences, and many individuals' family experiences have been around caretaking of parents, particularly if they have had underlying mental disorders or substance use in their family. And so when women and men become nurses, many times that they bring with them their own trauma experiences, which puts them in a vulnerable position of being more at risk for ongoing traumas, having had previous traumas, or that their childhood experiences were rocky and didn't provide them with the ability to manage their own stressors as well as other people do. One of the things that Paula brought up is that the number of nurses in the ICU were very young, that they had not been long out of nursing school and may not have the same coping skills as older nurses, perhaps. And so because the ICU being a very quick environment to remain in, if nurses do not have in place their own buddy system, for example, because of the fact that they're relatively new into the profession, that they may be less able to respond to the ongoing stressors that they're experiencing. One of the things that comes up is that the most readily available anti-anxiety agent out there is alcohol. And so many people may choose to have a nightcap when they come home, and that over a period of time, this may develop into an underlying substance use disorder. Unfortunately, nurses have at readily availability of substances such as opioids or benzodiazepines through their work environment, and which puts them at risk for increased use. One of the things that haven't had a chance to talk about, but is playing in the background of COVID, is the ongoing opioid epidemic. And so, with nurses being at risk, that opioids have, one could say, an advantage in the sense is that they decrease pain, and the pain that they decrease is both emotional pain as well as physical pain. And so that across time, nurses have had the opportunity, just because of the frequent and ongoing handling of such medications, to use substances um, to manage perhaps their own pain or to fuel their own addiction if they come into nursing with an underlying substance use disorder.
I'm so glad you brought up substance use disorder because there's quite often a stigma in nursing that we have to be resilient, we have to be steadfast, we have to be able to cope in any environment and stay true and not have any vulnerabilities. And what that does is set up a perfect storm for potential failure in who we are as nurses. And I think we can all believe in that because we do have to understand our vulnerabilities to be able to move forward. So when you're talking about substance use disorder, I'm glad you mentioned it because it is really about breaking that stigma, not letting that be a hush hush sort of conversation because people need to recognize that. So when we talk about stigmas, I want to spend some time talking about other stigmas within healthcare in just a minute. But we do have a question from our audience I want to take before I move on to another stigma that is not uncommon at all in healthcare. A question from our audience: can online connections via social media and texting and so forth, video chatting, can that adequately substitute for that in-person connection? And I open that up to anyone because that is so true. We have been relegated to FaceTiming, to Zooms, and I think we can all say that a lot of times we're zoomed out. It's how does that, can that equate to that in-person element? Paula, do you have an opinion on that?
Well, it's my personal opinion that it does not. Now, you mentioned several forms. You mentioned texting. If you're texting with a good friend and they just can't speak on the phone, then of course that's fine. But social media such as Facebook, there's many sites that are set up even for well-being of nurses, but unfortunately, it's also outlet for others who feel to say something negative, which could just fuel their bad feelings even more. So I'm a little leery about social media as far as getting together with others, but in person is wonderful. Texting with a friend, that's great too.
Yeah, thank you so much, and that's so true. And which that could be a show in its own talking about social media. So I'm glad I'm glad you mentioned that. So Tina, can we talk more about the other stigma in which unfortunately, in some cases, people feel so disconnected and isolated they have no outlet, and they might resort to a decision of taking one's own life. Can we talk some about suicide?
Yes, and I believe we have to talk about it because based on that study where the graphic was showing a high rate of depression, high rates of isolation. I mean, that study was of the American Nurses Association sponsored that study, and it's a huge current study of 9,500 nurses who have been who repeatedly studied, surveyed during the COVID outbreak, and what it is revealing. And by the way, these 9,500 nurses on average are much more experienced nurses, older nurses, and they are having a hard time too. So, as Paula was saying, the younger nurses have been like baptized by fire with the COVID epidemic, a pandemic, and the nurses who have a lot of experience are stressed as well. Um, Now, not everybody experiences stress in the same way, and thank goodness. But I would just to put in a plug for the American Nurses Association, they are very much advocates for optimal working conditions. And as we know, that has been challenged with the nursing shortage, as well as with the preponderance of a huge number of patients. I believe at one juncture in August, there was a negative number of ICU beds in the state of Alabama. So, unfortunately, that seems to be subsiding now. But the point is, the workload is tremendous. And as Dr. Foger said, most of us enter nursing because we really want to help others. And here are these conditions that are causing us to have negative emotions. In fact, if you looked at the criteria for PTSD, a lot of us would have met those criteria, meaning that we would have qualified for a diagnosis of PTSD. Now, the good news is treatment works. Treatment works for PTSD, anxiety disorders, and depression. It really does. The bad news is there's still stigma about getting treatment. And the bottom line that I wish everybody could say to themselves and remind themselves when they're having difficult emotions around stress related to COVID is that it's not about mental weakness, it's about biology. And that we can learn to understand our biology and learn resiliency and wellness skills. There's definitely hope. There's definitely hope to prevent suicide, to affiliate with one another and resume our normal social support mechanisms. There's hope for the future. The problem is that when you've been repeatedly exposed to trauma, as a lot of nurses have been during the COVID epidemic, there's a lot of burden that nurses carry. So I really think that prevention of suicide is important to think about. Earlier this year, the Association of Critical Care Nurses asked me to write a blog about prevention of suicide. And I think we have to say the word suicide, and we have to have a buddy system. We have to understand that it's a transient mood state. It's that if we talk about it, we're not going to cause somebody to go over the edge and die by suicide. We have to be open, and we have to rely on the latest evidence about prevention of suicide. And it's especially poignant that earlier this year, there was a study published in JAMA Psychiatry that showed that nurses have the highest rate of suicide amongst the health professions. It's true for both men in nursing and women in nursing. So, what Dr. Foger said about a buddy system, that's very important. That's very important because we're designed to live amongst one another, and COVID really took that away from us. And the support that we can give each other is huge. And by naming these mood states and these stressors, we can really go a long way to fighting the stigma that's been associated with conventional assessments of what stress really is. Because we now know we learned in the late 1990s and early 2000s we need to practice trauma-informed care, because what happens to you is hugely important and it shapes your worldview. Now we know about resiliency-informed care, and there's a lot that healthcare systems can do to improve resiliency skills and create working environments where nurses can thrive.
Thank you. Thank you for sharing that. I'm so glad. I'm glad we're having the discussion, because you're exactly right. Because people need to understand, to take away the stigma element, to have that conversation about suicide is how you get to that preventative state, how you're able to reach those that might be vulnerable. And you started talking about something about resilience, and I'd like to spend some time talking about resilience, getting to know resilience a little bit more, because for a perfect example, our nurses who've been in nursing for a long time, we've been ups and downs in different things, whether it be new leadership, staffing shortages, this issue, that issue. But we have nurses now who come into this as their first experience. This is their first experience in that space. We have built resilience over time. Yes, we're just as vulnerable, but we've built resilience. How do we get the new graduate nurse, the new the nurse who's very new to the field, to get them to understand resilience in the time of COVID? Suzanne, do you have an opinion on that?
I do. Opinion, in the sense, is that part of this being a learning process, that people don't come to the life having relationships and fully understanding the different ways that they can take care of themselves. And so part of this process is that healthcare facilities can provide something called resiliency training, which helps the nurse be a better human being, a better healthcare provider, and first and foremost, take better care of themselves. So that self care, which has been overutilized throughout all of this, is really about recognizing the individual for the value that they bring, and that daily assigning to themselves self care, which translates to taking care of themselves. Um, I consider it as a person cannot take care of other people unless they take care of themselves, and use the model of being on an airplane when they come on and say, if you have a child sitting next to you and the oxygen bags drop down, put yours on first, because you can't take care of anybody else unless you take care of yourself first. So some of the things that can happen, and this is not about calling something a disease process, but much more about managing wellness and continuing to be able to function, so that we consider that normalcy be good sleep, that it be about hygiene, and that it be about finding balance with nutrition. And so many of these pieces are about really helping people to understand what role they take in taking care of themselves. The most valuable thing that they own is their own health and their mental well being. And that is something that requires daily maintenance.
Yeah, this is such a good analogy too. Whenever you're talking about the airplane, the oxygen mask, that's a great way to place it, because it really is about taking care of self, because you can't care for others. So, as we're getting closer to the end of our time together, I do want to address another issue, Paula. When it comes to a lot of our nurses, most all of our nurses have become surrogate families and surrogate persons within the ICU, as some of our COVID patients have fallen victim to the disease process. They've become surrogates in the sense that they were the last person there with them. And that can be very difficult, not only for the provider, but also families as well. For the providers, for the nurses who are there day in and day out with, in that role of surrogate, what resources are available within the health system or any of the health systems to help them overcome this?
Well, I would say that their nurse manager would be a good resource. Other nurses, like we've talked about, just talking about it with other nurses, those are also good resources. And then if you feel that you would like some professional help, then that is an avenue that you should pursue. There should be someone that you can talk to alleviate some of the psychological stress and trauma that you've gone through.
That's a great resource. I know a lot of the hospital systems have, employee assistant plans and programs and so forth. So all of that kind of fits into a great series of resources. And, any other resources that you have, specifically with your work with psychological trauma, do you have any other resources you'd like to share with our audience today?
There's usually a counseling center if you work in a hospital, so that would be a great place to meet with someone. That would be a great first step.
Excellent. Thank you so much for that resource. And I'd like to talk to our other guests, Tina and Suzanne, about what resources are available for PTSD. So Suzanne, what what type of resources are available for our individuals who are struggling with PTSD or either substance use disorder as well?
Are we speaking specifically at this university or in general? I would speak to in general, in the sense is that there are some excellent treatment choices out there. I have experience with working with eye movement desensitization and reprocessing, which is EMDR, which helps individuals who have trauma to essentially process through it so they're able to get on with their life. It does not take it away, it just puts it into a different perspective and allow the individual to take a look at it and then move on. So it is treatment works, is what I can say. And that in this process, if nothing else, to kind of normalize the sense that seeking treatment is part of taking care of yourself as a human being. Group therapy is also very helpful. However, I would say that for nurses to begin to think about the fact that uh, they can create their own buddy system, which would be people that they can reach out to and plan to reach out to on a routine and regular basis, not just when they're in crisis.
Excellent. Thank you so much. That's a great group of resources. Tina, what resources do you have or can you recommend for those who are struggling or considering or contemplating suicide?
So what we know from the research about nurses who die by suicide is that the most common way that they die is through overdose. And Dr. Foger was mentioning about the availability of substances in the workplace and how it could easily happen that nurses could get hold of these substances. I believe that we can also see a pattern for nurses who are becoming increasingly distressed. And often they have co-occurring mood and anxiety symptoms. So if you see your buddy, your work buddy, starting to become more anxious and more nervous and seems to be reacting, basically also exhibiting symptoms of some post-traumatic stress, you can intervene and you can have a crucial conversation and say, I'm concerned about you. What's going on? And then you can kind of reveal a little bit about your stresses and in that way make it a dialogue, because those dialogues are so important, dialogues of concern. And so I think we need to teach our nursing students coming up about how to recognize symptoms of PTSD in other nurses and our colleagues. And so it's okay to ask for help. It's okay to say, I'm not perfect here. And, I need some help. And UAB has a fabulous app called the Be Well app. And it's not unlike other apps that, like the VA has a COVID app for veterans, but all these apps are encourage people, they coach people. If you sign up for it, you can get reminders. And if you're a UAB employee, for example, a UAB nurse, you can sign up for the app, take the quiz, take the assessment, and it will send you reminders to do things like spend some time with people who support you, go outside and expose your brain to sunshine, and get outside and exercise. All of these things are associated with recovery from stress and anxiety. And I think we have a graphic that talks about multiple activities that have been shown to renew the well-being of nurses. And I believe it's from that. Yeah, there it is. Activities to strengthen well-being. Talking with colleagues, exercise, expressions of gratitude. In Alabama, we have a lot of spiritual focus, and that's certainly something that has been associated with strengthening one's well-being. And it's whatever works for you. A lot of times, a resource for strengthening well-being is an animal, a pet. Or it can be whatever the the individual wants it to be. And that's the beauty of it. We can develop our own resources. And indeed, that Be Well app that I mentioned has a place to store photos in the app of your resources that do strengthen you.
Excellent. Thank you so much. Some great resources. So we're approaching our time today. So in our last minute together, I'm going to go around for just a quick soundbite final takeaway. So Suzanne, what final takeaway do you have for our viewers?
Just for nurses who are out there to recognize that each of them are precious and that they are valuable resources to themselves most particularly, and that if one's not feeling well, to consider what needs to happen to get feeling better.
Excellent. Thank you so much. I appreciate that. Tina, what do you have as a final takeaway?
It's okay to ask for help. It's not mental weakness that you're experiencing stress. And finally, treatment works. Treatment really works. And we have every few months you hear about something that's working better for treatment of stress, PTSD, and anxiety.
Excellent. Thank you. And Paula?
I would say just talk with others about what you're feeling, what you're going through. That's totally okay. And do something good for yourself. Do something nice for yourself. Just a little self-care. And don't be afraid to get help if you need to.
Excellent. Thank you again. And thank you all today. We really appreciate it. This has been such a great discussion about something very, very impactful to many of ours, family, friends, people we know, and nurses within our community. And what great takeaway messages, and we really appreciate it. Thank you again for being with us, and thank you all for watching us today. We'll see you next time on Clinical Pearls.
If you liked this video, please remember to like and subscribe, and click the bell icon to get instant notifications when we release new videos. Thanks for watching.